Um, can somebody allow me to share it just to check whether everything is in?
Yeah, sure. I'll just make you a co-host also, so that you can share it without any hindrance. So we start letting people in by 5 p.m.
4:55, Ajay. So 5 you can start. Right?
Yeah, sure.
You can see the screen, right?
Yeah, we can see it.
Thank you, sir.
Actually, I couldn't see it.
Sir, good evening, Dr. Kiran this side. Hi, sir.
Hi, Doc. Yeah, Kiran.
How are you, sir?
Yeah, fine, Kiran. Yeah.
Okay. So we'll start at sharp 5, sir.
Yeah, 5. Yes, we'll start at 5.
Okay, sir. Okay, sir.
You know, Dr. Ajay, Dr. Srinivas, I think you can see him in the screen. He is
Yes,
our
sir. Hello, sir.
hero today.
Hello.
Okay.
Huh?
Hello, sir. How are you? I'm Dr. Kiran
Yeah.
from Sun Pharma Medical Affairs.
Hi, Dr. Kiran.
Hi.
Good evening, sir.
Hi, good evening, Amal. Yeah. Kiran, another minute to go.
Yes, sir. Yes, sir.
Ajay, ready? Dr. Srinivas?
Yes, sir.
Ready? No, yeah.
Ready.
Okay.
Good evening, sir. Srinivas, sir. This is Dr. Amal here, sir.
Good
Hi,
evening.
Amal.
Hi, sir.
We are live on YouTube.
Right.
Okay.
Yes,
Yeah.
Kiran will
Yes,
start,
sir. We'll
Kiran.
start. Sure, sir. A warm good evening to all the audience who have logged in today. And I am Dr. Kiran from the Medical Affairs team of Sun Pharma. And it's my great pleasure to welcome you all today for this very, very interesting webinar. And on behalf of the Radiant Division of Sun Pharma, the topic for today is new avenues in thoracic malignancies. And to take it forward, we have with us none other than Narasimhan sir. Sir is well known. However, I would like to say a few words about sir. Sir has got immense experience of more than 3 decades. Currently, sir is a senior respiratory physician in the Apollo Hospital. Sir is the chairman the prestigious Respiratory Research Foundation of India, and sir has given many talks with more than 3 decades of experience. He has done more than 20,000 bronchoscopies. He has done more than 500 fluoroscopies. Sir has presented and published many papers and given many talks. And sir has organized several national and international chest updates for India on behalf of this foundation. And sir has done more than 400 asthma screening camps and conducted more than 500 awareness talks. So with this small introduction, I would like to welcome Narasimhan sir to take this session forward and moderate the session. Welcome, sir.
Thank you, Dr. Kiran. It's a great pleasure, and also my pleasure to thank Sun Radiant for this unrestricted grant on all our educational projects in the past and probably in future too. As you rightly said, what we are going to talk today is new vistas in thoracic malignancy. It is a relatively new topic for many pulmonologists. If 10 years back someone would ask what is a cyber knife, I think we would not have known what it is actually. At least some of us have heard of it, but we've still not been introduced to it in a very big way. And so when I was just talking to Dr. Srinivas some time back, he said, I'd like to share. I said, definitely, I also would like to hear. It's not the question of my sharing. I like to hear from you what actually is it actually. Same will be the interest of my postgraduates too, because this is an entirely new field. As I was telling 10 years back, if someone had spoken about malignancies, there is a loss of hope. You know? We would have said nothing can be done for it. Oncology means it's a last phase. I remember when I joined Kidwai as consultant pulmonologist, and I was really depressed because I thought I wouldn't be able to do anything for people. Now it is an entirely different story now. We're able to offer. Our next case, which Dr. Ajay is going to discuss, is one such case where we thought there is absolutely no hope. The guy remained, had his lungs remain collapsed for more than 6 months. We thought nothing can be done for it. We gave chemo and then we went on to surgery, and it's a surprise that this patient went back home very early. So these are some of the great success stories, and I'm very sure Dr. Srinivas would have many such stories up his sleeve, and would also appraise us of what actually is this cybermind, what actually is this Apollo proton. Sandwiched between these two topics of cybermind and Apollo proton would be the talk by Dr. Ajay and his team, Dr. Amal, about how we manage the case. And I also would like to get the input from Srinivas on whether there are any options of radiation in this treatment schedule. With this small introduction, I'd like to invite Dr. Srinivas, who is a radiation oncologist with Apollo Proton, has immense experience, trained in Mumbai, worked abroad, got trained abroad. He has been trained in radiation ablation and cyberknife and proton therapy. One of the busiest practitioners here and visit Apollo for more than 2 years now since Apollo Proton started. Yes, Srinivas, you are there with us from the time it started, right?
Yes, sir. 3 years.
Yeah. So he has been with us for more than 3 years with us. And I now invite Dr. Srinivas to share his thoughts on cyberknife first. Dr. Srinivas.
Thank you, sir.
Just 1 minute, Dr. Srinivas. Before we start, I would request all the participants to turn off their videos and mute their mics so that we consume less bandwidth and the streaming goes unhindered. So it's a kind request for all these participants. Thank you very much. So over to you, sir. So I'm just muting myself and stopping my video.
I would really like to thank Narasimhan sir for giving me this opportunity. I think I agree with Dr. Narasimhan that there was at least a sense of nihilism when we spoke about patients of cancers, patients of, in fact, any patients of any tumors, especially in thoracic malignancies. And there was a time even when as a young faculty in radiation oncology, when someone was asked, would you be interested in taking over thoracic malignancies? And a lot of them said no to it because of this sense of nihilism. And some people like us who kind of raised their hands and stood in front and said that we would be interested to take up this challenge. And now thoracic malignancies, thoracic oncology has seen great changes in last decade or two, especially in the last 7 to 8 years. It has seen major changes in the form of better and better systemic therapies with patients surviving much longer. For example, now recently, one of the trials which is published in Journal of Thoracic Oncology, of course, it was presented at European Society of Medical Oncology, has mentioned that for the first time, stage 3 lung cancer median survival was more than 4 years. So that was really unheard of a few years back, when we typically used to see a median survival of about 2 years for stage 3 lung cancers. For stage 4 lung cancer, specific category of patients now are surviving up to even 5 years and beyond because of the advances in the management of lung cancers. And fortunately, radiation is also making some headways in the field of thoracic oncology. And one such development is CyberKnife. Let me first tell you, some kind of disclosures that CyberKnife is a medical equipment company made by a company called Accuray. I'm not here to talk about the company, or I'm here to only talk about the applications of CyberKnife, because we are fortunate to have CyberKnife in Apollo Hospital, Chennai, and at Tenampet for the last several years. And we have been using the same for many patients of cancers. But just to introduce you, sir asked me to talk, in a very succinct manner for about 10 minutes, how radiosurgery and how CyberKnife helps our patients. So essentially, before you know CyberKnife, you need to know what is radiosurgery, because radiosurgery itself is a concept which has evolved over the last few years, essentially last 8 to 10 years. And typically the difference between radiosurgery and radiotherapy is in the number of sittings, approximate number of fractions. Typically, radiosurgery is delivered over 1 to 5 or 1 to 8 sittings compared to radiation therapy, which is typically around 5 to 7 weeks. Of course, it's rapidly changing, but essentially it means that it is hypofractionated. That means less number of fractions over lesser period of time. And the average dose per fraction, as you can see, is much higher compared to what we deliver on a daily basis in radiotherapy. And typical fractions is about 1 to 5 sittings. As I mentioned, radiotherapy typically is given over 30 to 45 sittings. Of course, as I said, it's changing. It is coming down in number as we speak for many sites. But typically, number of unique beams per fraction is 1 to 200. Radiotherapy, we use 5 to 10. Of course, that is also changing. Typical targeting accuracy is less than 1 millimeter because we only treat for 5 sittings. So we can afford to be really precise on a daily basis. Compare that to radiotherapy, where we because it's spread over a few weeks, the accuracy may change, precision may change. So I think 3 millimeters is what is typically seen. 20 millimeters was for the yesteryears. The clinical intent through radiosurgery is to ablate the tumor, whereas in radiotherapy, it is to cumulatively give doses to control the tumor or eradicate the tumor. So there are subtle differences between in radiosurgery and radiotherapy, and I hope you have clearly understood the essential differences. So CyberKnife robotic radiosurgery system is a machine essentially to treat patients with radiosurgery. So this is a machine which cannot treat patients on radiotherapy, like you have 80% of your indications are radiotherapy for a majority of the tumors. Radiosurgery is essentially a very specialized technique. When the technique is being used, CyberKnife comes into play. It's of course a linear accelerator like what we use for radiotherapy, but it is mounted on a robotic manipulator, on a robotic device. It delivers independently targeted beams with high precision under continual X-ray image guidance. I think these 5 lines are unique and probably you may not understand, and that is why I have chosen to show you a few examples and show you some pictorials. This is a typical linear accelerator. This is called a gantry. This is called a couch. This is where the patient lies down. The radiotherapy beam is delivered through the gantry. There is a waveguide behind. There is X-ray device which comes out. High energy X-rays are produced, and then they are diverted to this gantry. And with a sub-millimeter accuracy, it can be delivered to a particular tumor. So similar, but if you see a CyberKnife, you see that the gantry is replaced by a robotic manipulator. This is the robotic manipulator. This is the couch, and I'll talk about the couch a little bit later, but this is the robotic couch. This is a robotic kind of a manipulator, which has got several degrees of freedom. And these are the stereoscopic X-ray imaging equipment, which are seen, and this is an infrared reading device. Conventionally, in linear accelerators, we treat basically something called isocentric treatment delivery. That means we keep the isocenter. If you imagine a sphere around which the gantry rotates, and if you place the isocenter in the tumor or close to the tumor or in the center of the tumor, just to make it easier for you to understand, and the gantry revolves around in a particular fashion. So essentially, from wherever the gantry is, it is isocentric. That means the distance between the gantry position and the tumor is essentially the same. And that is why we call it as isocentric. And typically for radiotherapy, we use a single isocenter. Compare that to a CyberKnife, it delivers independently targeted. So it is non-isocentric. So there could be the gantry could be closer, farther away. So you see that the distance between the center of the tumor, the centroid of the tumor, and the gantry device is varying for each of these beams. So you can imagine this somewhere in the tumor, somewhere in the body, the tumor is lying, and you target by using multiple beams with varying isocenters and varying distances from the isocenter. So typically the delivery is non-isocentric. This essentially gives CyberKnife multiple degrees of freedom, which is unmatched or unparalleled as far as the normal conventional linear accelerator is concerned, especially when we are dealing with a radiosurgery a technique. So this is the treatment couch. It's translational. Of course, we have a robotic couch now, even on the linear accelerator, but the degrees of freedom are limited. For example, if you want the patient's body to be rotated, or to give a pitch to the body, or yaw, it is almost it is possible only to an extent in a conventional linear accelerator. But if you see a CyberKnife, you have a robotic couch that makes it possible for us to give many more degrees of freedom in terms of many more degrees of freedom in 6 dimensions, not just in 3 dimensions. It is translational in lateral and in longitudinal directions, but also in the rotation, pitch, and yaw direction. So the 6 degrees of freedom, which is possible on a robotic couch, that is enabled on a CyberKnife device. Normally, when we do image guidance on a linear accelerator, we have something called X-rays. We call it as orthogonal X-rays, which are obviously orthogonal because 90 degrees separating. This is a X-ray kind of a X-ray source, and these are the receiver. This is the X-ray source. This is the receiver, or the one which reconstructs the images, and this is what we see. And of course, because X-rays are available, we can also do something called a cone beam CT. So we have a volumetric image guidance when we deal with linear accelerator. Whereas when we deal with CyberKnife, we have, as I mentioned, 2 X-ray units. They are not orthogonal, they are fixed, they are not rotating with the gantry, and because of which they have a little varying angles as far as X-rays are concerned, which are not we are not used to. So what we do normally is we generate a synthetic image with the fiducials, because we always place a fiducial, because we are not able to see the tumor in 3 dimensions. We put fiducials into the tumor. We place the fiducials into the tumor pre-treatment, and we use these fiducials to localize our target, and we make something called a synthetic image, which is generated through a CT scan. This is the actual image which is captured when the patient is lying down on the couch, and we try to match the patient's CT information on which the actual plan was generated with the patient position, which is captured with the camera A and camera B, depending on the angles. And then we overlay and we see that within a millimeter, the target is lying, and then the radiation therapy is delivered. So apart from this, so one small aspect which is missing in CyberKnife is a cone beam CT, but because we have fiducials and we have all these devices, it can circumvent the problem of not having a cone beam CT. Similarly, especially when it comes to lung tumors, and especially when the lung tumors are moving, we need to continually track the tumor with respect to the motion. So when we say if it is moving continuously, we do something called a gross tumor volume. We give something called a CTV, but there is a large planning target volume or internal target volume, because we have to kind of take into account the motion of the tumor, and that is why we had to give larger margins. With the CyberKnife, what we can do is we can track the tumor, and because of tracking tumor, we can reduce the margins significantly. And how do we track the tumor? Tracking the tumor is through 2 devices. One is the X-ray imaging, which happens continuously over a period of time, and there is a belt which the patient wears, which captures the respiratory movement. So this is the respiratory belt which the patient is wearing, and these are the X-rays. So both of them together combined can track the tumor very, very reliably. And of course, there is a lot of quality assurance which goes into it to ensure that each day, for each patient, for each plan being delivered, the quality of the treatment can be perfectly maintained. And that quality assurance is done on a daily basis for the machine, for the patient, for the plan generated, and to ensure that the quality the plan is exceptionally high. So just to give an introduction, this was the intent, not to go into details, but CyberKnife is a highly specialized radiosurgery equipment for intracranial and extracranial tumors. Radiosurgery is a preferred modality for stage 1 lung tumors, which are either medically inoperable or when patient refuses surgery. And there are more and more acceptance of this modality, especially in elderly patients who have multiple comorbidities where surgery is a difficult proposition. Radiosurgery is also useful in patients with metastatic disease to the brain and bone. So we commonly use radiosurgery for solitary brain metastasis or solitary bone metastasis. In fact, even when the lesions are up to 5, and there is a philosophy where up to 15 brain mets also could be treated with radiosurgery, but that is still evolving as a concept. So radiosurgery can be used for either a primary lung tumors or in metastatic setting, because we know that about 60% of EGFR mutated lung cancers have brain mets. At some point of the time, they would need irradiation to brain. So essentially, this is just to give a small snapshot of CyberKnife. I hope you have all understood clearly. Thank you so much.
Thank you very much, Dr. Srinivas. That was a great talk with just an introduction to CyberKnife. It was really very good. I think it's sufficient for most of us to write a short notes on CyberKnife for all the postgraduates. It's a nice talk anyway. I will keep the questions to the last half an hour. 6 to 6:30 we'll have the question and answer session. I now ask Dr. Ajay and Aman to take over their case presentation. Ajay, over to you. Both of you should unmute. Ajay and Amal, both of you should unmute.
Yeah. Unmuted. Hello. Yeah.
Hello, sir. Good evening, sir. This is Dr. Amal here. Can I start my presentation, sir?
Yeah,
Ajay,
you
sir,
can
please.
start your presentation. Amal, I'll just share the screen for you right now.
Sure, sir.
So can you see the screen? I don't think so.
Yeah, I can't see the screen. Yeah. Now I can see.
Yes. Now we can, sir. So, good evening, everyone. I'm Dr. Amal Johnson, and I will be presenting a rather interesting case today. So, next slide, sir. Next slide. So, this is a famous scene from Alice in Wonderland, where suddenly Alice sees a big cat sitting on a tree. She's so surprised by the size of the feline, and she says that curiouser and curiouser. It is not even a proper English. So our case is something similar to this. So this is a 41-year-old gentleman from Bangladesh without any comorbidities who was having progressive breathing difficulty for the past 1 year. So he was subsequently evaluated there in Bangladesh, where he had a chest X-ray and a CT chest scan, and he found to have a mediastinal mass. So he had underwent a CT guided biopsy there, and the biopsy was suggestive of a soft tissue sarcoma. So he was started on treatment there by the medical oncologist. He was given 3 cycles of chemotherapy with efosfamide and doxorubicin. He had come here to our cancer center for further management. He was evaluated by a medical oncologist here, and a PET CT was done, which was showing an heterogeneously hypermetabolic mass involving the right hemithorax with an SUV of 11. He had no other demonstrable lesion, and so the medical oncologist planned for a palliative resection followed by an adjuvant chemo. He had referred this patient to a cardiothoracic surgeon for a surgical option. So this is the chest X-ray of the patient who had an entire hemithorax whiteout right side with a significant mediastinal shift to the opposite side. So in pre-operative evaluation, this patient had a 640 slice CT angiogram done, where we can see this is an heterogeneous mass with areas of necrosis occupying the entire hemithorax, pushing the trachea, pushing the important vessels, great vessels. Sir, next slide, sir. So pushing the great vessels here, and So next slide. And the thing, as you can see in the coronal section of the CT scan, this mass is occupying the entire hemithorax from the apex until the diaphragm with the moderate pleural effusion on the right side. The printed report given
I'd like
by
to
the
just chip in here. I'd like
Yes,
to just chip in here with the radiological findings. So, see what happened. Can you hear me? Yeah.
Mm.
So, what happened was
Yes, you can.
this mass was. You can see the SVC here. The pointer is on the SVC. You can see the SVC is literally stretched over the mass, and you can see the IVC, which is visualized up till here, and just the supradiaphragmatic portion of the IVC is not visualized. It's maybe completely compressed or infiltrated. So we didn't know
Yes, sir.
there. But overall, the plane seemed okay. That's why we agreed for resection for this patient. So with this thing, we'll go forward.
So
this was the
the
report by the
report,
radiologist.
so the report by the radiologist was an heterogeneous mass lesion occupying the entire right hemithorax with an approximate size of 28 to 22 into 16 centimeter. It was compressing the right main bronchus with the resultant collapse of the right lung. The mass is highly vascular with feeders from right IMA, DTA, and right splenic vessels as well. He had there is a significant mass effect with compression of right atrium, closely related to the pericardium, and the mass was displacing the great vessels as well. So next slide. So there was no evidence of involvement of trachea or esophagus and the vertebra and the ribs. The mass is closely adherent to pleura, and there was a right moderate pleural effusion. There was no evidence of focal lesion in the opposite lung. So on that thing, at that time, this patient on examination, he was patient was dyspneic at rest. He was unable to lie down flat. He was saturating well on room air, but he was tachypneic with a respiratory rate of 25 per minute. And the features of SVC obstruction was just beginning to appear that time. So we had a multidisciplinary team meeting with the pulmonologist, cardiologist, medical oncologist, radiologist, the anesthetist, and thoracic surgeon. We had given a special importance to pre-evaluation and pre-operative preparation and planning before the surgery. So there was a plan of embolizing the major feeding vessels to decrease the intraoperative bleeding. But unfortunately, the patient was not willing for the procedure. So we had to arrange for blood products before the surgery. So as per the anesthetist advice, we had placed invasive blood pressure monitoring CVP lines, and inotropes were on board to tackle hemodynamic compromises if arise. So the anesthetic consideration in this patient would be the mass was compressing the major airway. So we were considering whether it would be a difficult intubation. This patient subsequently had a double lumen tube, but the anesthetist was very skeptical about intubation that time. After intubation, we were able to ventilate the patient, but initially the patient had very high peak pressures. We had arranged for adequate blood products, and hemodynamic monitoring was there. Next slide, sir. So under general anesthesia, the patient in left lateral position, the postlateral thoracotomy was done. As we were previously discussing, this patient had a huge mass occupying the entire hemithorax. The mass was adherent to the right middle lobe and right lower lobe. So the adhesions were removed with blunt and sharp dissection carefully. And next slide, the mass was excised in toto, which was friable and broke into fragments after resection. Hemostasis was secured with the wound closed in layers. The patient was extubated on table and shifted to recovery.
This is the post-op appearance. I'll just chip into this. This is the post-op appearance of the hemithorax after the removal of the mass. You can see how beautifully the lung has expanded. You can see the upper lobe, the middle lobe, and the lower lobe. You can see actually a fissure separating the sixth segment and the common basal segments. So that's how beautiful his lung was. Underlying lung was absolutely normal, and you can see the mass is completely out. Lung expanded completely.
So
over to you.
This was like a vanishing lung syndrome, isn't it, sir? So this was essentially like
almost a vanishing lung. Then its lung came back. That's the thing.
Yes, fine. And the post-operative was uneventful. He was shifted to the recovery, and the tumor was excised in toto though, after removal, it got separated into fragments. So the thing is, as you can see, 3 fragments of different sizes. The mass was weighing approximately 10 kilos. Next slide, sir. So in the immediate post-op, you can see in the chest X-ray, there is complete expansion of the right lung. This is beautiful, I would say. Next slide, sir. The ICD was removed on post-operative day 3, and the patient was discharged on day 4. The patient is currently on follow-up. Now, the biopsy was suggestive of an high-grade pleomorphic sarcoma. The thing is, as you can see in the pathology slide, which is shown in here, there is a haphazard arrangements of spindle-shaped cells in a myxoid stroma with the mitosis of 14% hyperfield and the necrosis of 30 to 35%. Next slide, sir. So this is the chest X-ray taken on 2nd of February when the patient is on a subsequent follow-up. As you can see, the underlying lung is fully expanded and the patient is symptomatically much better. Next slide, sir. So coming to the discussion in this important presentation, so I would like to ask Dr. Ajay's comments on the preoperative planning in this patient. Yeah. So can you share us, sir? Yeah.
Yeah. See, the case has been well discussed by Dr. Amal. Of why this case, why we decided to present this case. This case, the moment I saw this guy in the outpatient department, I was not convinced myself whether he would be a candidate for surgery, because they have already tried 3 cycles of chemotherapy and sarcomas being chemo resistant. He has not improved at all. So in a non-improving patient, whether I have to burn my fingers, go in, that's where your decision making and consulting with others, where you can get a lot of ideas, an extra pair of eyes. So you always involve many people in the MDT and get their inputs. So that's when we decided we should do a 640 slice CT chest. A normal PET CT, their arterial and venous phase protocols are different because the focus is mainly on the oncologic part and not on the anatomical part. That's where our PET CT. I'm just going back to the radiology. So you can see the brilliant detail. You can see the vessel here. This is the innominate and SVC junction. You can see a small branch from the thing. It is feeding into the vessel. So our radiologist told me you have to be careful at this point when you're scooping out the tumor, because there won't be any vision. The tumor is occupying the entire hemithorax. There won't be any vision. You be careful at this point. So at this point, when I'm putting in my hands, I know I have to be careful and you should not do anything rash. At the same time, this is the venous phase, and this in the arterial phase, you can see the aorta and the pulmonary artery. When in the arterial phase, the tumor is lighting up with a blush of vessels. So these are the vessels that Amal was saying could be tackled by a preoperative embolization in conjunction with the interventional radiologist. But for some reason, the patient was not willing for the procedure, maybe due to the financial constraints, or maybe because of the time you needed to wait to reduce the bleeding and all that. And you can see the right pulmonary artery, which is compressed completely by the mass, but there is a nice plane here. You can see the fat plane being maintained. All these details are not available on PET CT, and it is, even though you might think it might be an overkill to repeat a CT within 2 weeks or something, but it definitely gives you a lot more thing. And again, in the venous phase, you can see the SVC and IVC, which is stretched over the mass. So the MDT gives us a lot of points and helps us in decision making. Number one. Number two, as I was again explaining it to you about the radiologist, you have to go and sit with the radiologist, not just depend upon the report. You go and sit with it, see what you want in this particular patient, and look at the anatomy in the way how you want it. The radiologists have evolved excellently. They have great softwares which can give you any view you want and reconstruct the tumor and the 3D anatomy of the patient. It will be like you're actually doing a virtual surgery for this patient. That is again important. And pre-op optimization. Apart from the embolization part, this patient would have actually benefited from some kind of blood transfusion, but our anesthetists were again very skeptical about pre-operative blood transfusion. His hemoglobin was only 7.9 on admission because of the tumor bleed or whatever, we don't know, or the chronic malnutrition. His hemoglobin was 7.9. His proteins were just borderline 3.1 albumin and all that. So this pre-op optimization is very important for surgery. So we had all the products on hand because our anesthetists were saying in pre-op transfusion is not recommended anymore. We will transfuse him intra-op. And so with our anesthetist conjunction, we went ahead and took him up for surgery. And the anesthetic considerations, what they were worried about was there is a significant mediastinal shift as mentioned by Dr. Amal and also the radiologist, they had commented, and the trachea was compressed in the lower part. There was no infiltration, but the trachea was compressed badly in the lower part, and there was absolutely no right main bronchus at all. Only the left main bronchus. He was breathing only through the left main bronchus. We were skeptical whether we will be able to intubate him at all. And then they decided to put in a double lumen tube. We'll give it a try. If not, we'll put in a single lumen and use a bronchial blocker if necessary. That was the plan. Apart from these intubation thing, your peak airway pressure, intubation is one thing, maintaining your ventilation is one thing. When the patient is awake, his muscular tone is there, his sympathetic drive is there, he continues to breathe. The moment you anesthetize him, there's a sympathetic blockade and all the muscular tone goes and the patient suddenly goes in for a tracheomalacia or what, you will be unable to maintain ventilation even though you have a tube inside. So that was one of the things that is very scary. And that's where we tried our best to put in a DLT because the bronchial lumen of the double lumen tube goes inside the left main bronchus and does not stay in the trachea. So even in case of a compression, at least the left side will be getting ventilated. That was one. Number two, the mediastinal mass syndrome, the so-called mediastinal mass syndrome starts even before the surgery because you have to make the patient lie supine for anesthesia. This patient was unable to lie supine because of the mass effect. It was causing compression, and putting him in on lateral position, it was a very difficult thing because the mass was going and falling on the RA, causing a compression, reduction in the venous return, and hypotension. So these are all the anesthetic considerations that we were considering, and the anesthetist had to manage each and every one of these problems. And of course, the blood loss and all that stuff. Then the surgical strategies. What kind of strategy we are going to follow up for this patient? The patient's attender, I know in their hopefulness, they asked me whether it can be done by a minimally invasive surgery. I told him, there's absolutely no way I'm going to put in a scope because I don't even have space to put in my hands. There is no way a scope is going to do you any benefit. You should know when to attempt minimally invasive, when to attempt open surgery. In this patient, there was no second thought about it. Only open surgery was the option because the tumor was almost 22 centimeter, if I'm right, Amar. 22 centimeters?
22 centimeters, sir. Yes, sir.
22 centimeters. So there's absolutely the minimally invasive surgery there's no role for this. And this patient was also hemodynamically unstable. So you had to do a thoracotomy. The real debate was whether to do a sternotomy or to do a thoracotomy. The advantages are there in both. In doing a sternotomy, you have access to all major vessels, and in case there is a cardiac problem, you can do a cardiac massage and all that. But the exposure is pathetic, and you won't be able to go behind and the posterior mediastinum. You won't know what is going on at that place. So we decided to go ahead with a thoracotomy and open the pericardium if required. That was the surgical strategies. And follow up after the surgery is over, you should be on correct follow because this is a soft tissue sarcoma. He has a preoperative diagnosis. You should know what needs to be done. So that part we left to the medical oncologist again. I think after the immunohistochemistry and all that, they have decided to give him one cycle of gemcitabine. I think one cycle has finished.
Adjuvant chemo, sir. This patient is on adjuvant chemo now.
Adjuvant chemo, right? Yeah. Adjuvant chemo, gemcitabine and
docetaxel.
docetaxel. And they are also planning a radiotherapy to the tumor bed, I believe. So that
I would
was
like
about the discussion.
Sir,
Yeah.
CT versus MRI in this patient, sir, as a pre-operative evaluation, what do you think, sir?
CT versus MRI. I would personally go for CT because I would also like to see the underlying lung. The MRI does not give you great information about the underlying lung. CT
sir.
with an angiogram is definitely better in these patients. But if you are worried that the tumor is invading the chambers of the heart, like the atrium, a cardiac gated MRI will be a great option because the MRI will match your cardiac cycle and take you in case you see a CT is just a static picture, you can see the right atrium and the mass in conjunction with each other, but you might actually be like in diastole, the mass falls off the right atrium, or rather the right atrium falls off the mass. That will not be appreciated in a CT, but that will be appreciated better in an MRI, cardiac gated MRI. You have to get like in proton server saying, as your moving, the tissue moves, and you can deliver a precise beam of radiotherapy according to the gated movement. This is MRI will be helpful there. So personally, I had a few questions whether there is any role for CyberKnife in this patient, or the post-op radiotherapy, whether it will be helpful for this patient. That were the two questions for which I had as a surgeon. How good will it be? Because his main concern was whether it will be recurring. This tumor will recur. That we never have an answer. But what all can we do to minimize the recurrence? I think I'll open the floor for questions.
Srinivas sir, can you take up
Yeah.
this question, sir? The role of CyberKnife and the role of post-operative radiotherapy in this patient.
Yes. Dr. Ajay and
I'll stop my share. Yeah.
Dr. Ajay and Dr. Amal, congratulations for a fantastic
Thank you very much, sir.
case. I think I have also learned something from this case. I think seeing such a huge mediastinal, so huge tumor in the thorax, it is very hard to imagine that we could achieve even a marginal resection in
Meaningful
this
recovery.
patient. And as I also treat sarcomas apart from thoracic at Apollo Proton Center, so I deal with a lot of sarcomas. In sarcomas, the value of surgery is, there is no value. It's invaluable thing which a surgeon can do in sarcomas, because sarcomas are considered relatively chemoresistant, relatively radio-resistant. So nothing works better than surgery in sarcomas. So in that sense, and the way in which the lung expanded dramatically in the post-operative setting, I think that
the intra-op itself, if you can see the video, lung was beautiful actually.
That would have given you a lot of satisfaction, and immediately that what you have done is probably the biggest benefit. I'm not sure whether the gem dosi will help. I'm not sure whether post-operative RT will help. But surgery has helped the patient. The quality of life is definitely better. Whatever life he's going to live, hopefully he will live a long life, but he will be comfortable. But one of the question which I wanted to ask Dr. Ajay and Dr. Amal is, Dr. Ajay, when you are operating, where exactly was the tumor originating from? Was it from the anterior chest wall? Was it from
Correct. That was one thing, because the pre-operative diagnosis, they had given it as a solitary fibrous tumor of the pleura. But I have my own doubts. Usually solitary fibrous tumor starts from somewhere laterally and compresses the lung from outside. Right. But this was between the lung and the pericardium. Rather, it was just on the hilum, which means it was in the maybe in the middle and posterior mediastinum rather than completely in the posterior mediastinum. So we had to actually open the pericardium to make sure that it was not involving the RA, and remove a small cuff of pericardium along with it.
Was it adherent to the anterior or any part of the chest wall at any location?
No, just small flimsy adhesions which were separated by diathermy. Apart from that, there was no. The main part of adhesions was the pericardium and the hilar structures near the lung. So we had to separate it. Our challenge was separating the mass from the hilar structures of the lung.
Because Dr. Ajay, for us, it is very important to understand the tumor bed, because there is no tumor right now, and we'll have to imagine the tumor bed for radiotherapy. Of course, it is not suitable for CyberKnife, because as I mentioned, CyberKnife is a surgical equipment, and there is no role for radiosurgery in such huge tumors. We will have to go for conventional radiotherapy. But for me, before I even advocate radiotherapy for this patient, I would like to understand where exactly is the post-operative bed, where exactly the microscopic disease would be still there. I think one location which you have made clear is the mediastinum, mediastinal structures, the pulmonary artery, the pericardium, the atrium, where the disease microscopically could be there in that region. For sure, I understand. But maybe any other location, you'll have to guide us if we have to plan any post-operative radiotherapy in terms of whether we have to delineate the chest wall around the pleura, maybe entire pleura for some dose of radiation, and to the higher dose to the mediastinal structures where there could be really higher number of tumor clonogens present still microscopically. So as you rightly said, the sarcoma, as I said previously, the surgery is the most crucial. There are 4 types of resections. One is a supraradical or radical resection, where even compartmental resection was performed, in yesteryears for sarcomas. Of course, in this location, it is impossible. Number two is wide local excision. Wide local excision is also not possible in this, because, as you rightly said, if somebody asks you whether you can do a minimal invasive, there is no place for you to put your, anything apart from the scope. So, I mean, similarly, I don't think wide local excision is almost
feasible in the thorax.
to remove the several mediastinal structures. The thing which you have done is a marginal resection, which is probably there are some microscopic cells around. So we'll have to localize those regions. The success of radiation would depend on how well we are able to localize the microscopic disease. And of course, pleomorphic sarcoma is an uncommon tumor, and we commonly classify undifferentiated pleomorphic sarcomas, and we also call it as MFH, or malignant fibrous histiocytoma. And the treatment is surgery. They are known to be chemo resistant. The role for chemotherapy is controversial, and rightfully so. The patient did not respond much to initial 2 cycles of chemotherapy. We hope he will respond. I mean, he will have some response to adjuvant chemo, but I don't think they are very sensitive to chemotherapy. So it is just chemotherapy is being given in a desperation, because we don't have any better modalities to offer the patient so that we can minimize the recurrence. Radiation is far better in terms of efficacy compared to chemo. But of course, the challenge is to delineate the post-operative bed, and it will be extensive. So I would also be not very keen to immediately push in for post-operative RT. I think chemo is the right option, which the MDT has chosen. And and after a few cycles of chemotherapy, once the thorax recovers, the chest wall, the lung expands completely, then there is a scope for me to spare a little bit of lung. So I think, I agree with the current plan of treatment as far as this.
My question was, he has undergone 3 cycles of chemotherapy in Bangladesh. Will it be better if early surgery is suggested, or this is the correct thing, like receiving a new adjuvant and
new adjuvant chemo followed by surgery?
Is this the correct?
Retrospectively, we have learned that since you have done surgery so well, so it was so smooth, and I think the patient would have benefited with for going for surgery upfront rather than giving chemo, because if at all the patient has not responded much. But in high-grade sarcomas, there is a role for preoperative treatment because it reduces the chances of metastasis. So in that sense, theoretically speaking, at least chemo helps for sure. But we have learned retrospectively that it did not respond, unfortunately. So again, I would agree with the current plan that you give chemo and then followed by surgery, which is the right plan. We did not know in the beginning that the patient would not respond at all. Some patients do respond with chemotherapy, some partial response, and then surgery would have been the perfect way to do. But now, after we see that there was no response, probably surgery would have been better in the beginning itself.
I think we'll
preoperative radio in this
next topic. Apollo Proton, and we'll have the discussion again.
Sure.
Okay, Dr. Srinivas, would you start your next topic? Actually, whenever there is an action like surgery, there will be more questions. I think there is something more interesting now we are going to hear, and after that, again, we'll come back to this discussion. Dr. Srinivas, over to you on your Apollo Proton.
Thank you. So this is another technology which is radically different compared to CyberKnife. CyberKnife, of course, is a linear accelerator. It uses X-rays. So we have all the strengths and limitations of what X-rays can offer. Proton therapy is entirely different, and especially I will, obviously, because of the audience, I would restrict my talk to proton therapy for thoracic malignancies, and today specifically for stage 3 unresectable non-small cell lung cancers. And this is a good opportunity for a radiation oncologist to interact with pulmonologists. So I thought I'll put up a few slides for stage 3 unresectable NSCLC. Stage 3, stage 2, in situations where we are giving chemo RT as the standard option, not surgical options. So in patients with such tumors, stage 2, stage 3, where surgery is not an option for whatever reasons, because of medical inoperability or surgical unresectability, adequate mediastinal staging is of paramount importance. Of course, we have experts of adequate mediastinal staging. We have both the surgeon and pulmonologist. The pulmonologist doing minimal invasive with endobronchial ultrasound and bronchoscopic guided procedures, and even in certain situations where depending on the location of the mediastinal nodes, even a thoracoscopic mediastinal staging is of paramount importance. Of course, PET scan is very, very essential, but we know the limitations of PET scans in staging mediastinum, and that is the reason why adequate mediastinal staging is essential. Apart from that, we have a dose of radiation which is typically given is around 60 gray in conventional fractionation. That is a standard of care, although I am a big believer of hypofractionation, and we will speak a little bit about it later. It is always combined with radiosensitizing chemotherapy. There are typically 3 regimens of chemotherapy, either paclitaxel carboplatin, pemetrexed carboplatin, or cisplatin etoposide, depending on either the fitness of the patient, depending on the histology. But most commonly preferred strategy is paclitaxel carboplatin, irrespective of the histology. If it is a non-small cell lung cancer, irrespective of squamous or adenocarcinoma histology. The dose volume constraints for radiation oncologists are extremely important. The key volume constraints, of course, the other thing which I have not mentioned is esophagus. Apart from esophagus, lung and cardiac doses, these are the 3 essential structures which radiation oncologists would like to spare as much as possible to ensure safe delivery of radiation. The key issue in lung cancer is motion management. So in CyberKnife, we have motion management like tumor tracking. Similarly, we need to have motion management even in conventional linear accelerators, which are as good as CyberKnife. We have something called 4-dimensional CT scans, which is conventional CT scans, but they also give information about the 4th dimension, which is the time. So with respect to the respiratory motion, with respect to time, where the location of the tumor is what we derive the information from the 4-dimensional CT scan. And preferably the technique has to be at least IMRT, which is intensity modulated radiation therapy. So this is what is the standard of care so far in stage 3 non-small cell lung cancers. Are we happy and extremely thrilled about them? Not really, because you see the benchmark outcomes which have been seen in large multicentric randomized control trials through either RTOG, which is Radiotherapy Oncology Group North American trial, or the Pacific trial, which was a trial with immunotherapy. Typically, the 2-year progression-free survival is only 30%. And with Pacific trial, now with immunotherapy, it's close to 50%. So 50% of patients essentially progress within 2 years in stage 3 non-small cell lung cancers, and absolutely nothing to be happy or thrilled about. And about 60% survive 2 years, 66% with immunotherapy. So this is very sober results as far as chemo-RT is concerned in this setting. Not just we don't have very great outcomes, the toxicity also, you see that grade 3 and more toxicity. This is with IMRT, this is the best X-ray technique we have, and this is the best results reported so far. We see nearly 70% of patients having grade 3 toxicity. That means patients requiring medical interventions, which is quite significant toxicity as far as lung is concerned. Typically, esophagitis is a dose-limiting toxicity. So you see that only 50% do not have progression, 70% have toxicity with grade 3. Dose to normal structures determine outcomes. Normally, dose to normal structures should determine the toxicity. So dose to esophagus to determine esophagitis. Dose to lung should determine the pneumonitis. But essentially, in lung cancers, dose to normal structures determine outcomes. Why is this? This is because excess dose to lung or excess dose to heart can actually kill patients, can actually lead to higher excess mortality. And that is why we see that heart V5, esophageal dose or esophagitis grade determines overall survival in lung cancers. That means, as I mentioned, dose to normal structures determine outcome. This is purely because we treat large tumors as when we see, say, stage 3 lung cancers. I'm just building the right momentum for why proton therapy in lung cancer. So there is another concept why normal structures cause toxicity. It is cardiac irradiation is known to cause significant morbidity and mortality. There was a perception that it is a late effect. That means if a lung cancer patient receives radiation, the effect of radiation on the heart would come after 5 to 10 years. That was the perception before. And there is a perception that it was a major concern only in patients with known cardiac issues. So if a patient has an MI, if a patient has an ischemic heart disease, only then we should be concerned about heart doses. It is not true. In fact, most of the cardiac events begin much earlier than 5 years. Effect is seen regardless of known cardiac risk factors. And there are multiple evidences which have shown that the mean heart dose determines the cardiac events rate. Less than 10 gray, 4%, 10 to 20 gray, 13%, more than 20 gray, 40%. So you have chances that patients have 40% risk if there is mean heart dose is more than 20, having pericardial effusions, having myocardial infarction after 1 or 2 years of radiation. Arrhythmias and other events, cardiac events. Now there is growing evidence that just not the mean heart dose, but there are other structures which are important. In fact, the most radiosensitive structure is the base of heart, which corresponds to sinoatrial node, and the region corresponds to cardiac conduction system. So there are multiple theories still we have not been able to completely figure out which is the most radiosensitive structure. Essentially, entire heart is radiosensitive, and we need to reduce the dose to heart to a significantly low level. And there is no threshold. Even 1 gray would affect the heart to an extent. So that is the reason, as I mentioned, we have been practicing X-rays for stage 3 lung cancers for so long. The results are not gratifying. The toxicity is high. There is risk of cardiac and pulmonary complications. And that is why we are discussing today why proton beam therapy. And you see that the difference between protons and X-rays with CyberKnife or X-rays with any linear accelerators, deposit dose within few millimeter under the skin, and there is attenuation as the X-ray beam goes along the body. So when it hits the tumor, say for example, the tumor is here, essentially the beam is attenuated already by the time the beam reaches the tumor. And that is why we need multiple X-ray beams to hit the tumor. Compare that to protons, there is a small entrance dose. The entire energy of the proton is deposited in within few millimeter of something called a range of proton. So a particular, say a 200 MeV proton has a range of about 28 centimeters. So after it travels 28 centimeter into the body, it deposits its complete energy, and there is absolutely no dose in the body after it deposits its entire energy. So this is called a Bragg peak. So there is a physical advantage of using protons in sparing the normal structure. So any normal structures beyond this would not receive any dose. Any normal structures before this would receive very, very minimal dose. This is the principle of Bragg peak, which is unique to X-rays. Based on this, one would say you would like to treat every patient on proton, and I'll come to that. Proton, as I said, protons stop. That is the biggest benefit. X-rays do not stop. They travel continuously. Apart from that, there is something called a biological advantage of using proton, because dose per dose between X-rays and protons are about 10 to 70% more effective than X-rays. And that is why typically in patients of sarcomas, patients of tumors which are more radio-resistant ones, protons are more preferable because they have more effective, they are radiobiologically more effective. For example, in the center, they are 15% more effective. In the distal fall-off, they are 70% more effective. So by use of some amount of biological optimization, we can ensure that most of the tumor is receiving higher doses than what it normally predicts dose per dose compared to X-rays. So similarly, if you see in protons, because it stops, you see that if you give a posterior beams, you see that the protons stop, and you see that the heart essentially a large portion of the heart is not receiving any dose of radiation. Compare this to the IMRT VMAT, which is the most modern X-ray technique which we use today. We give high doses in the tumor region, but we unfortunately spill the lesser and intermediate doses to the entire body. So you see that there is some greenish tinge in this. So this is intermediate doses to the chest wall, to a little bit of heart and other structures. In fact, even the stomach, because the diaphragm is moving. But we essentially give a lot of dose to the liver, to the lungs, to the heart. And because we are entirely radiating the heart, and as you know, when we radiate for about 2 to 3 minutes with X-rays, we essentially treat the entire cardiac output. So the cardiac output, whatever lymphocytes and whatever the WBCs are present, they're also receiving full doses of radiation, especially when we are irradiating the mediastinum, our heart. And that has shown that patients who have lesser reduction in lymphocyte count only because of radiation, they have a better survival compared to those patients who have more irradiation to the heart with low doses. So there is an immunological advantage to proton as well, apart from physical and biological. So there are now, obviously, as all scientists, we believe in evidence and we look at evidence. There is a large national cancer database analysis. Of course, we know the limitations of national cancer database studies. Within these limitations, after propensity matching for all covariates, which could significantly alter the outcomes, you see that the hazard ratio for protons for all patients is about 1.21, for stage 3, 1.35. That means with a confidence interval of 1.1 to 1.6 and 1.06 to 6 to 39% more effective, about 21% more effective than in terms of overall survival as well as disease-free survival with respect to proton compared to X-rays. Similarly, for stage 1 lung cancers, where SBRT through CyberKnife or other techniques are being used, even in those patients, using protons has resulted in superior outcomes and lesser grade 5 and grade 4 toxicity, grade 3 pneumonitis compared to conventional CyberKnife or conventional X-ray based SBRTs. So radiation pneumonitis is significantly low, the toxicity is significantly low, the overall survival is better with compared to X-ray based SBRTs when it comes to stage 1 lung cancers. Of course, I would be doing a disservice if I don't quote this negative randomized trial. This is a randomized trial between proton versus photon at MD Anderson Cancer Center at Houston. This was a pragmatic trial or a Bayesian adaptive trial, which essentially mentions that there is a lot of patients are not typically randomized to 2 arms. The patients are randomized on basis of a lot of information, which is like an algorithm. Essentially, it ensured that patients who were randomized to protons could not receive protons because of insurance disapprovals. Those patients who were randomized to X-rays did not receive X-rays, and some received protons because they wanted to go for proton, which is a better modality. So essentially, there was a lot of hoopla in terms of statistical jargons, and there was a lot of issues with the design of the clinical trial. And more importantly, there is something called passive scattering proton therapy was used. I showed you that if you don't use modern intensity modulated radiation therapy, use large fields, you don't use motion management strategy, you don't have image guidance, you use large safety margins. And those were all used in these trials because these are previous generation proton therapy trial. But essentially, it showed that the primary endpoint of radiation pneumonitis and local failure was not different between IMRT and passive scattering proton therapy. The hard dose was significantly low with proton therapy, but it also had a learning curve as far as proton therapy was concerned, which was not present in IMRT. I will not go into detail, essentially saying that there were several limitations admittedly by the authors of this study. And this study cannot be a benchmark as far as proton versus X-ray is concerned, although it's a randomized trial, it's a Bayesian randomized trial, and we know that passive scattering is actually inferior to what technology we have, something called pencil beam scanning proton therapy. After the introduction of the pencil beam scanning, this is what is there at Apollo Proton Cancer Center, with use of magnet scanning magnets. We deliver multiple Bragg peaks to all these points, spot by spot, layer by layer, and covering the entire tumor. And that is why we call this as intensity modulated proton therapy. And after the introduction of IMPT, thoracic malignancies constitute about 20% of all patients treated with protons in United States. This is from University of Washington in St. Louis. About 30% were genitourinary cancers, 20% were approximately thoracic malignancies, so most of them being lung cancer. So there are now multiple phase 1, 2, 3 randomized trials for protons for lung cancers. These will be awaited. This will take about 5 to 7 years for all these results to mature. But meanwhile, we have this facility available, and we are treating routinely lung cancer patients with proton. This is one of the patients which I would like to illustrate. This was a 63-year-old gentleman who had presented to a hospital in Mumbai with a squamous cell carcinoma of left lung. He was staged as T3N3 because of a contralateral hilar node which was present. He is a diabetic, hypertensive, and about 120. He weighed about 120 kg. He was a high risk for surgery. Of course, in N3 disease, we would not routinely offer surgery. This was the PET scan, and the radiation oncologist in Mumbai planned for an IMRT technique. And what they noted, and this was a very reputed center in Mumbai, what they noted was volume receiving 20 gray was 36%, volume receiving 5 gray to lung was 61%, both resulting in a probability of grade 3 toxicity of pneumonitis, which is potentially life-threatening, of 40%. I also showed you the mean heart dose. What is its significance? The mean heart dose here was 30 gray, which also meant patient had 40% chance of grade 3 cardiac events within a span of next 2 years. So this was considered a prohibitive plan, and the patient was asked to go to medical oncologist to go for chemotherapy, hope for some debulking, and then we will reassess again. And then the patient contacted us, and what we did was we planned on proton beam therapy, and we saw a dramatic reduction in the doses to lung and heart. You see, we have published this, the dose to heart, 30 gray compared to 7.2 gray with proton, which essentially reduces the probability of heart toxicities to less than 5%. The dose to lung V20 was 36% in conventional IMRT. Compare that to IMPT, it was 22%. Again, very, very significant reduction. V5, 61.5% to 35.5%. Again, a significant reduction in the doses to normal heart and lung, which actually determine the outcomes. And thereby you see the probability of grade 3 toxicity was reduced from 40% to less than 5%. We have treated nearly about 22, 23 patients of lung cancer. Some of our 2 patients are on treatment right now. We have treated locations in upper lobe, on the right side, left side, very close to pericardium. Patients who have been irradiated before, very close to the hilum. So re-radiations have been treated on proton as well, to extremely satisfying outcomes. So to conclude, proton therapy has a definitive dosimetric advantage over IMRT in lung cancers. It could reduce the rate of pneumonitis and cardiac toxicity, which essentially determine the clinical outcomes in these patients of lung cancers. Early results are encouraging with low toxicity outcome, and I can speak on a basis of our own limited experience in the last 2 years. In view of the cost, obviously the patient selection needs to be judicious, because the cost is obviously prohibitive for some patients. Safe dose escalation through proton, through hypofractionation, which is lesser number of fractions, is being tested in combination with concurrent systemic therapies in multiple clinical trials in various parts of the world. We are also started a single arm, a phase 2 observation trial, just to capture the quality of life in patients. So we will hope that we will also have some personal experience as far as the quality of life in these patients is concerned. And with that, I would like to thank once again Dr. Narasimhan for giving me this opportunity, and I would be happy to take any questions.
Thanks, Dr. Srinivas. That was a very good talk introducing pulmonologists to this interesting topic. We now have with us Sundaramurthy. Are you there, Dr. Sundaramurthy? Professor of... I saw him.
He's
Right.
there.
He's there, eh?
Yeah.
Sundaramurthy, if you are there, you can ask the question that you are planning to ask. Anyway, I have a question, Dr. Srinivas, before anyone else starts. You were talking about cyberknife for stage 1 malignancies in patients who are not medically fit or who are not keen on surgery. I would just like to know whether there are any studies between the two people. I thought offering surgery to a stage 1 or stage 2 would be a better option. I just like to know, are there any studies to compare, head-to-head comparison between cyber knives and operative therapies, Dr.
Sir, there are two large randomized trials which were initiated in Europe, which in fact I had the honor of visiting one of those centers, which was Dr. Professor Suresh Senan in Amsterdam. He was the principal investigator of that study. The study was prematurely stopped before accruing the full number of patients, and the studies showed that there was no difference in terms of survival between surgery and radiation therapy for stage 1 lung cancers. Having said that, that was not an adequately powered study, but essentially it actually showed that surgery, patients who underwent surgery had a dip in outcomes in the immediate post-operative period because of mortality, some patients dying of surgery due to surgery. But essentially, over a longer period of time, there was no difference in survival between radiation and surgery. In fact, if I'm given an opportunity, maybe in the future, I would like to present those studies. Those are very interesting. Again, there are two studies which will accrue a good number of patients to answer this question. The benefits of surgery are that you would get the histopathology, you would get the mediastinal staging appropriate before we initiate the treatment. Those are the biggest benefits of surgery. But having said that, those studies which have compared surgery versus SBRT have shown equivalent outcomes in patients of early lung cancer. And that is why surgery is still considered the standard of care in stage 1 lung cancers. And only in those patients who are either inoperable or refusing surgery would only come to us for radiation therapy.
Thank you, Narasimhan. The term inoperable, that's the only thing. In stage 1 malignancy.
Yes, sir. Medically,
your
no.
comments on that, Ajay?
Yeah, that's what it. I've come to realize there is a difference between unresectable and inoperable. So if resectable malignancies might not always be operable because of so many other comorbidities. So that is why those SBRT studies had very, very less participants, if I'm right, maybe in 2 digits or 3 digits only. They did not garner a lot of it because not many people were accepting to the fact that stage 1 malignancy should be subjected to SBRT. So still patient, but I would like to say that with the advent of VATS, even in the septuagenarians and octogenarians, we are able to do surgery
That's
safely.
what I was just thinking of. Yeah.
So because we recently had a patient with CABG who was incidentally detected malignancy, stage 1. She had come for a angiogram, CT angio. Then in the CT angio, they found a lung nodule biopsy to be an adenocarcinoma. She underwent a VATS, right upper lobectomy, and third day she was discharged. So still that acceptance to SBRT, I don't know whether maybe 90 plus and 100 plus where people will not be willing for surgery, then they might give them an option or something.
Yeah. So you're right, absolutely. With the advent of minimal invasive surgeries, more and more patients are getting operated. There is no doubt about it, but the SBRT rates also have significantly increased. Now, most of the guidelines mention SBRT as an alternative. And that is why patients are also, even if there is a slightly higher risk with surgery, whenever the surgeon mentions that there is a slight risk with surgery, obviously they would consider an opinion with radiation oncologist. I agree with you that surgery is still the standard of care, and there is no doubt about it. And essentially, we get a lot of information from the histopathology. Of course, there is also a small thing that in case if well, I mean, still, I mean, these days, segmental resections are also coming into vogue, and
Sublobar resections.
you don't need to do lobectomies. So I think more and more with lesser and lesser invasive surgeries and lesser, conservative surgeries, we are seeing better and better outcomes. So yes, so SBRT remains only a option in patients who are not keen for surgery or inoperable for whatever reasons.
One question before you go on to the audience, Ajay. There are a lot of questions in the chat box.
Dr.
I just want to ask you, this stage 1 malignancy which you were referring to, were they are biopsy proven, CT guided biopsy proven, or
CT guided biopsy proven.
Most of them are CT guided biopsy proven. In fact, some of them have undergone mediastinal staging as well.
Dr. Narasimhan.
Sundaramurthy, yeah.
Thank you, Narasimhan, Dr. Ajay.
Yeah.
Dr. Srinivas, I have a basic doubt.
Yes, sir.
Any absolute contraindication for proton therapy? Absolute contraindication.
Sir, absolute contraindication for proton therapy would be one, those patients who have very, very mobile lung tumors who are not amenable for breath hold techniques, who have erratic motion, who have cough, who have severe COPD where the patient is unable to lie down supine for a significant period of time. These would be my typical contraindications. As far as patient logistics is concerned, the other is obviously there could be a relative contraindication where the patient has collagen vascular diseases where we know that radiation would be more toxic in them. We would like to avoid radiation in such patients.
Thank you, Srinivas. What is the impact of stem cell therapy in the proton outcome? Proton therapy? Is there any study or anything? Stem cell therapy.
Stem cell therapy.
Stem cell.
Stem cell therapy.
Sir, stem cell therapy is completely in a different...
Totally different, I agree. But regarding the thoracic lesions, I'm just...
Okay, sir.
As far as I know, I don't think there is a big role for stem cell therapy in lung malignancies as yet. That's my take on.
Yes, sir.
We are suggesting it as a panacea for everything, but I don't think for lung. I think for lung malignancies, with the advent of the cyber knives and the minimally invasive surgeries and segmentectomy that are coming into vogue, I think that will be a better way of treating these lung malignancy patients.
Yeah.
Thank you,
just wanted to
Thank
ask you, Dr. Srinivas, these patients who underwent SBRT, you said they were mediastinally staged, right? What category of mediastinal staging do you take up for SBRT? Just for an academic thing? So N1 or N0 only?
No, only N0. So SBRT by definition has to be used only in patients who have N0 disease. So N0 disease has to be proven by means of a PET scan for sure.
And then a mediastinoscopy maybe?
And in a mediastinoscopy, in case there are anything which is suspicious, it needs to be staged. So in Western countries, obviously, it is easier because the negative predictive value of PET is very high. In our patients, the negative predictive value is not so good as them. And that is why we probably need some amount of mediastinal staging before we can prove that the patient is indeed N0.
Okay.
From the chat box, there are some questions.
Yeah, there are some questions.
Yeah.
Sridhar has asked a question. Any role of proton therapy in palliative treatment in stage 4 carcinoma lung, like an endobronchial tumor? If so, which is better? Localized bronchoscopy guided cryoablation or proton?
So the philosophy of cancer treatments do not change with the advent of proton. Proton is a much safer form of radiation therapy. So of course, proton therapy can be used for palliation, there's no doubt. But as I mentioned, because the cost is a factor, it needs to be used judiciously. We cannot use it for palliative reasons. We would obviously use that proton therapy is a standard of care in pediatric malignancies. Any child who is likely to survive longer, any child, teenage, young adult, any child who would survive longer, the proton therapy would be standard of care, because they would not see the toxicities of radiation in terms of toxicities to heart and lungs. Even for lung cancers, patients who are likely to survive longer these days could be subjected to proton therapy. But I would really not recommend proton in a setting of palliative nature because of the cost.
Okay.
If cost is not a consideration, Srinivas, would you, it's a head-on just in comparison between the palliative radiation and proton, which one would you prefer it? The cost is not a consideration, or the insurance bear the cost, means would you?
Yes, sir. If cost is not a consideration, proton therapy in most situations would be a safer form of radiation therapy compared to any other form of radiation. Let it cyberknife, let it be any other form of radiation, because the protons stop. X-rays do not, and therein you can spare better normal structures. So essentially, in all situations, it would be theoretically better. Only issue is where you want to use. I mean, if money is not a consideration, if there are no technical issues, protons can be given in any patient, essentially.
That is not far away. I think the time will come where proton may replace too, right?
Yes, sir. Hopefully, with smaller footprint, with a lesser cost, if it replaces a linear accelerator, because it's definitely more attractive than a linear accelerator. So definitely in future, hopefully it will make a bigger impact.
You do the same kind of radiation fibrosis and so on with proton. Are there any studies, or we are relatively new and we don't have data on that?
No, sir, much lesser. So the lung fibrosis, the lung scarring, the pneumonitis, significantly lower with protons. The normal tissue sparing is.
You do find them.
Yes.
You do find sometimes.
Yes, sir. There are multiple situations where we have found that we have irradiated and the lung looks nearly normal. There is no scarring because we have used protons.
We have one more question. Proton therapy in lung cancer, which histological subtype has a better response? And role of radio frequency ablation in large inoperable tumors. I think there are two different questions.
Yeah.
Proton therapy in lung cancer, which histological subtype has a better response?
So there are no such differential responses. We know that squamous cell carcinomas are better responsive in general to any radiation
therapy. Correct.
Yes. So that way protons would be obviously intuitively more responsive in squamous cell carcinomas. But I would not say that, let us prefer proton for squamous or X-rays for adeno, nothing like that. In fact, more radio resistant ones would be the situations where proton therapy would be more preferable, because they would have a more radiobiological effectiveness compared to conventional X-rays. The next question is radio frequency ablation. Of course, I am not the one who does it. RFAs are typically done by the surgeons or the interventional radiologists. It is a very attractive modality for smaller tumors, not for large tumors. For smaller tumors, in inoperable, unresectable tumors. But I think
medically inoperable tumors, right? That.
Yes, absolutely right. But Dr. Ajay, I would hope that after this talk, you would refer those patients to us, because inoperable, you would prefer the least invasive, and radiation is indeed a least invasive modality. Compare that to cryoablation, which essentially will need some amount of invasiveness.
I have one question, Dr. Srinivas. These radio-resistant tumors, when you give this proton therapy, how do you assess the response to this treatment? At least in surgical, you take a CT scan or X-ray and see. With chemotherapy in small cell, you can see the PET scan and see the lesions disappearing, nodes disappearing. But in radio-resistant tumors, you subject a patient to proton therapy. How do we assess those patients? Just for a
Yes, sir. Essentially, you're talking about, say, a sarcomas, which are not resected, or a solitary fibrous tumor, which is say inoperable or is not operated, and we have chosen to give radiation for whatever reasons. So these are more radio-resistant tumors. In terms of, they are benign tumors. They are more benignish in terms of the range. So typically, what happens after radiation is that they stop growing, essentially, and shrink over a period of several years. So what we use is a very good question you asked, because what we use is MRI, and we use T1 perfusion. So we use body perfusion to see the responses, because you see pre-treatment, the body perfusion, if you see the T1 perfusion, the curves are much more steeper, and they become much more flatter after the treatment. So T1 perfusion coming down significantly is a good bioimaging marker. And of course, the PET, if there is an SUV uptake, the SUV uptake comes down significantly in these tumors. So these are ways to see subtle responses of radiation, sir.
Okay. Then
Any
there's
other
one more question. Recurrence of stage 1 lung malignancy after cyberknife therapy. Yes, that's the question I wanted to ask. Recurrence of stage 1 lung malignancy after SBRT, cyberknife.
So let us call it as SBRT, because cyberknife is a brand name of a machine. So
Correct.
after SBRT, the recurrence is obviously, the recurrence would be local recurrence, regional recurrence, and systemic recurrence. The chances of local recurrence are less than 5% or about 5 to 7% after SBRT. The chances of regional recurrence are up to 15%. This is the I'm quoting from the largest SBRT study ever. And of course, the systemic recurrences are the highest, and typically they are seen up to 25%. So essentially, what we see is within 2 years, whatever recurrences we are seeing are those which have been missed in the staging phase. For example, if you see a mediastinal recurrence within 6 months or 8 months, we know that probably we haven't done adequate mediastinal staging, and that is why they have recurred within 6 months. But if we see recurrences beyond 2 years, they are fewer. So if you do a good staging, good mediastinal staging, then you would see actually about 5%, less than 5% local recurrence, less than 15% mediastinal nodal recurrences.
Okay.
There is one more question, role of chart. This is a kind of a very passion for me. Chart is continuous hyperfractionated accelerated radiotherapy. This was first used in United Kingdom to a dramatically good results. Of course, there were many issues with chart. It has to be given over even 3 times a day, even including the weekends. So then there is something called chart 12 came, which is weekend-less chart, but chart weekend-less. So it was omitted on Saturday and Sundays. Just imagine in NHS system where a chart being delivered, it was faced with a lot of negativity and criticism. But essentially, it showed that there was a significant benefit. So essentially, what it theoretically showed is if you reduce the overall treatment time to from 6 weeks, which is what we use, 60 grain 30 fraction over 6 weeks, to approximately 2 to 3 weeks, or chart 12 4 weeks, you gain a significant amount of tumor control. But the issue with chart is we cannot combine it with chemotherapy. We know the benefits of combination chemotherapy when we combine it with radiation, and hence what I do at Proton Center with tomotherapy, not with protons, with tomotherapy, we are using hypofractionation routinely, which is commonly used even in United Kingdom. 55 grain 20 fractions with chemotherapy, or 60 grain 20 fraction with chemotherapy, essentially reducing the overall treatment time for 6 weeks to 4 weeks, which we have seen some dramatic response. We will publish it soon. We are maintaining a database of hypofractionation. So hopefully that will show us the way in the future of lung cancer. A lesser number of fraction would be more beneficial.
Thank you. That's actually a very exhaustive and extensive explanation. There's just one more question. Will pleural effusion affect the efficacy of proton therapy? Sometimes the effusion may be paramalignant in the early stage of lung CA. Will proton therapy be beneficial?
So whenever we see pleural effusion, obviously it is a stage 4 malignancy. we do not prefer to give radiation as an upfront modality in a stage 4 tumor unless it is an oligometastatic or there are many caveats for it. Pleural effusion essentially makes it a slight relative contraindication to radiation therapy in general when I'm dealing with the primary. So unless it is as you rightly mentioned, a symptomatic effusion or effusion because it's localized effusion, which is sterile effusion, which is mainly because of the pressure effects rather than
the malignancy itself.
Yeah, malignancy itself. So those are the subtle things, but I wouldn't say that pleural effusion, as I said, is if I see a malignant pleural effusion, I would not give proton therapy, or I would not even offer radiation therapy upfront. I would subject the patient to chemo first, and then we can assess later in terms of what we can do.
Okay. One question, I think we left 2 questions are there. Chemo therapy, proton therapy, sequential or concurrent, which one is better?
Concurrent. There is no doubt that concurrent is better than sequential.
Okay. I think that was one question for me. Neoadjuvant chemo or radiotherapy will be friendly or unfriendly to the surgeon, technically, like alternating the anatomical areas at the surgical site. I would like to tell you, it's the most unfriendly thing that can ever happen to a surgeon operating on a post-chemo or a post-RT patient. All tissues will be friable and it will be bleeding like hell. There will be a lot of fibrosis around the vessels and the tissues will be stuck to one another. So it's not really nice operating on such patients.
What's the purpose of this neoadjuvant chemotherapy?
Sorry, Dr. Ajay, but I would like to ask in case, in stage 3As or stage 3Bs, sometimes after chemo RT, if there is disease only localized to the primary or to the regional nodes, would you consider surgery in such patients?
Yeah, definitely. I mean, if there's no other option, I think, but I would not enjoy that surgery. That's what I would like to say. See, doing surgery upfront is really good and nice, but doing surgery, especially in this patient who has received 3 cycles of chemotherapy, everything was hard. Even that lung, the tissue between the lung and the tumor was hard. You had to really fight and find out each and every step, whether you're cutting through the tumor or you're cutting through the lung, or you won't actually know the difference. That's the main thing. I think Dr. Sridhar wants to say something. I'll just unmute him. He wants to. Sridhar, you are unmuted.
Sir, good evening, sir. Dr. Sridhar. Sir, that question that the chemo radio will be unfriendly, but proton, how about proton, sir? It also will cause the same effect as other radiotherapies?
I think I will answer that question.
I have no experience.
Yes,
sir.
Even with proton therapy, the maximum dose would be around the tumor. So I don't think it would be any different for Dr. Ajay if he operates post proton therapy, unless if you see the rest of the lung would have less scarring, the pleura would have less scarring, but essentially the place where he would find most difficult to dissect, the lung, the primary and the mediastinal nodes, he would find it as challenging as radiation. That is my guess.
Another question. Yes, sir. That's another question regarding the effusion. I wanted to ask the paramalignant effusion due to obstruction of the endobronchial due to pressure effect. In that case, if we are planning for proton, the proton beams are traveling through the effusion, it will affect the efficacy, or the effusion won't affect any efficacy, but the localizing the site will be difficult, sir.
Very good question, Dr. Sridhar. I hope it was an innocent question. I hope that you don't know a lot about protons, but you hit the right question, because if the proton is indeed traveling through the effusion, it may have a dose perturbation. So we make sure that, because the effusion can vary on a daily basis, we make sure that the proton beams are not traversing along the effusion. So we can change the beam orientation to ensure that it doesn't travel through the effusion. Thank you, Dr. Sridhar. That was a very good question.
But would you recommend draining the effusion before you apply proton beam? I think that will be a better option, right?
Yes.
It will be fairly constant for you to
ICD in and then the proton.
ICD in.
Yes.
Huh? Okay.
And what about non-expanded lungs? Will there be any difference? Like
So,
you drain an effusion, he has an endobronchial mass, upper lobe expands, lower lobe does not expand. We are left with a space. So we sometimes put in an IPC, but these guys go in for recurrent effusions. Even if you drain the effusion, there's a huge space between the chest wall and the lung.
so we do face that same issue. So obviously, um, the lung expansion is a key issue. So we have something called a cone beam CT, which we do on proton or on radiation on a daily basis. And whenever we see that there is a lung re-expansion happening, we obviously have to do replanning because the lung is changed now. The anatomical positions are different now. So we'll have to perform a replanning on that patient on a regular basis to ensure that whatever dose we intend to give, that continues. So indeed, we do an adaptive radiation therapy. That is called an adaptive RT. Whenever we see pleural effusions going up and down, lung expanding or collapsing, so we do that.
Okay. I think we have finished off all the questions in the chat box.
I think we have come to the end of the session. I'd like to thank, first of all, Dr. Srinivas for his time. It's a very nice talk. We enjoyed both your SPRT and the proton therapy, Dr. Srinivas.
Thank you,
And
sir.
I also thank Dr. Amal and Dr. Ajay for their presentations. And of course, Dr. Kiran for being there in the beginning and helping us in all our things. And radiant people have been with us the past 1 year from the time the corona started. We were doing this program. And I also thank all the audience because without them, I don't think the thing would have been very interesting. Though it is a relatively new topic, we had a fairly very good listening audience participating in the discussion. It was very easy for us. Thank you all and wish you all a very